corticosteroids, vitamin C, and thiamine for the treatment of severe sepsis and septic shock. My PICO question is, in patients over the age of 18 with severe sepsis and septic shock, can intravenous corticosteroids, vitamin C, and thiamine, compared to those who do not receive intravenous treatment, improve mortality outcomes during their hospital stay? Sepsis is estimated to affect around 15 to 19 million people annually, with a mortality rate of 20 to 35% in those with severe sepsis, 50% in patients presenting with septic shock, and up to 60% in low-income countries. That's one person every 2 minutes. According to Sepsis Alliance, sepsis accounted for around $24 billion in annual costs, making it the most expensive condition to treat in the entire United States. The average expense for sepsis hospitalizations in 2013 was over $18,000 in the United States. That's 70% higher than other hospital stays for other conditions. In addition to short-term mortality, these patients also suffer from short and long-term complications, with a reduced quality of life and increased risk of death up to 5 years following the acute event. So my case study is a patient with the initials of AH. He's a 55-year-old male that presents to the emergency department with excruciating back pain for 1 week. MRI showed a spinal epidural abscess. His vital signs are as follows. His blood pressure was 90/40, respirations are 31, oxygen saturation is 94%, and his pulse is 112. His temperature is 103.5 degrees Fahrenheit, and he also has mild confusion. Upon lab draw, he shows a white blood cell count of 15,000, procalcitonin or PCT of 5, and a serum lactate of 5. Blood cultures were also obtained from the patient. He has started on a sepsis bundle and started on rapid administration of lactated ringers at 30 mils per kg, and also started on intravenous Levaquin at 750 milligrams IV and admitted to the ICU. Due to multiple comorbidities, this patient is not a surgical candidate. After a consult with the neurosurgeon, the patient is not a surgical candidate due to the following. The patient is a type 2 diabetic with a hemoglobin A1C of 15 and a history of heart failure. Surgery presents a high mortality rate for this patient. Cardiology, infectious disease, and nephrology are following the case to manage the patient's comorbidities in the hospital, so he will continue his at-home medications. For my theory, I use Betty Newman's systems model. It is a holistic and systems-based approach to patient care. The systems model is equated with wellness and defined as the condition in which all parts and subparts or variables are in harmony with the whole of the patient. Newman goes on to explain that the environment as the total of a person's internal and external forces and how they interact. Internal and/or external stressors can affect overall wellness. So it kind of just explains that the patient's internal and external environment have to be in harmony in order to achieve equilibrium and wellness. The environment has 3 components: the internal, which is within the client system, the external, which is outside of the client system, and the created, which is an environment that's usually subconsciously created by the patient. This model also focuses on primary prevention, which includes health promotion, secondary prevention, which occurs after the patient reacts to the stressor or the illness, and tertiary prevention, which occurs after the patient has been treated and tries to reduce energy needed to facilitate the overall reconstruction and healing from the illness. So at this point in treatment, the patient in the case study would be at the tertiary level of prevention. The sepsis bundle, along with a proposed sepsis cocktail, would ideally assist in reducing the patient's energy needed for reconstruction and reducing stressors. So it would ideally prevent the patient from progressing to septic shock or severe sepsis to septic shock and organ failure. Stress and ACTH act on the adrenal gland, which in turn releases vitamin C into the adrenal veins normally. So vitamin C in this case would act more like an internal stress hormone than a nutrient. The environment would also need to be conducive to the healing process, so the patient and family should be educated on the treatment plan, given updates with the lab results and imaging, and be allowed to have a say in the patient's overall care and treatment plan in order to provide holistic healing. So the current practice guidelines that we have now, the signs of sepsis would be a white blood cell count over 12,000 or less than 4, or 10% bands, respiratory rate over 20 or a PaCO2 of less than 32, temperature of over 38 degrees Celsius or less than 32 degrees Celsius, a heart rate over 90, an elevated lactate of over 2, and the diagnosis criteria would be elevated white blood cells, febrile, suspected source, and clinical suspicion overall. So according to the Surviving Sepsis and International Guidelines for the Management of Severe Sepsis and Septic Shock, in the patients that meet the sepsis criteria, the sepsis bundle should be started within at least 1 hour of arrival. We would obtain blood cultures prior to the administration of antibiotics, administer broad-spectrum antibiotics until the cultures came back, and we can then narrow those antibiotics down. And we would rapidly administer 30 mL per kg of crystalloid fluid for hypotension or a lactate greater than or equal to 4. And then if that doesn't help the blood pressure to come up or to get that MAP at 65 or above, we would then apply vasopressors if that fluid doesn't help. So in the study that was originally done by Merrick, he chose 47 consecutive patients over the age of 18 that were treated during a 7-month period. These patients all had the same baseline characteristics. He did not explain if these patients were female or male, but he did say that each patient had a different kind of origin for their sepsis. The IV vitamin C was given 1.5 grams every 6 hours for 4 days or until the ICU discharge. The IV hydrocortisone was given 50 milligrams every 6 hours for 7 days or until ICU discharge, and was then followed by a taper of over 3 days. And the IV thiamine was given 200 milligrams every 12 hours for 4 days or until ICU discharge. So in these patients, the hospital mortality of the ones that were treated with this vitamin cocktail was only 4 out of the 47, which was 8.5% compared to those in the group that were not treated. 19 of those 47 in the control group did die from complications. So that's 40.4%. And they did progress from severe sepsis to organ failure and septic shock. So the gaps in evidence right now, additional studies are still needed to confirm these preliminary findings from the Merrick study. There's still a lack of large, multi-center, randomized blinded studies that need to be done. This original study only had 47 patients total, which isn't enough to confirm the results. And overall, less than 20% of eligible patients with severe sepsis and septic shock are commonly included in many of the sepsis trials, which limits the applicability of the results. Other studies have only used the ascorbic acid or the vitamin C instead of the sepsis cocktail, which also includes the hydrocortisone and the thiamine. And it's thought that these three together work synergistically to reduce those pathologic effects that progresses the patient from severe sepsis to organ failure and septic shock. Since the intravenous sepsis cocktail is so new, there's still a lot of studies and research that needs to be done. So a plethora of technology is needed to manage and treat sepsis. Imaging machines such as MRI are needed to check the effectiveness of treatment on the source of the infection, so in this case, the spinal epidural abscess. The electronic health record, or EHR, is needed to track and manage the patient's vitals, labs, and their overall course of treatment. IV pumps and scanners are needed to provide safe medication administration. Some ethical considerations to consider when giving this vitamin cocktail. Although very little exists when delivering the vitamin C, hydrocortisone, and thiamine, we do need to consider the quality of life of the patient after potential survival. So if this patient has a stage 4 cancer or some other comorbidities going on, we need to think about what we are bringing them back to if they do survive this. Some concerns have also been voiced that high doses of vitamin C can induce pro-oxidant effects, increasing the risks of hyperoxalasis and oxalate kidney stones. So this complication has not been seen in short-term IV vitamin C doses of less than 14 grams a day. In patients that the oxalate level did rise, which was 3 of the patients in the Merrick study with previous kidney stones, the levels fell back to normal following treatment. It is also thought that the thiamine assists in keeping those kidney stones from forming. This vitamin cocktail doesn't consist of any expensive designer molecules, but it does have 3 inexpensive agents that are readily available and have long safety records in the clinical use since 1949. Some APN implications. So in patients that meet the sepsis criteria that we talked about earlier, the sepsis bundle should be started, preferably within 1 hour of arrival. The patients are to continue any at-home medications, typically if they have comorbidities. The antibiotic of choice, which is a broad spectrum, should be initiated at least within the first 6 hours, but the sooner started, the better. And again, those antibiotics, once the blood cultures come back, will be narrowed down to something more specific to treat that infection. Every 30-minute delay in antibiotic treatment does increase the morbidity and mortality measurably in sepsis. Fluids, which lactated ringers are preferred, should be given as a 30 ml per kg bolus initially. If that doesn't bring that MAP at or above 65, we start vasopressors, which should be started after the fluids. Levofed would be given first, and then vasopressin, and then if that MAP still isn't at 65, we add epinephrine. We will trend the patient's lactate every 6 hours until it's below 2. More studies still need to be completed before we consider using the vitamin cocktail on patients like those in this case study. For collaboration in cases like this, upon diagnosis and identification of severe sepsis or septic shock, infectious disease should be consulted. In this case, since the patient has a spinal epidural abscess, we would consult neurosurgery just to review the MRIs and determine the need and eligibility for surgery. Nephrology may also need to be consulted in the cases of renal impairment, diabetes, or acute kidney injury. And if there are any existing comorbidities such as heart failure, cardiology may also need to be consulted. So some quality improvement initiatives that we need to look at. The current sepsis bundles that we have now and the treatment protocols do not treat the underlying pathophysiology responsible for the progression from sepsis to septic shock. So that's why a lot of patients progress so quickly and go into organ failure. Vitamin C has also been shown to improve standard treatment protocols by reducing that inflammation and supporting the hemodynamic instability, which is common in sepsis, especially when used synergistically with hydrocortisone and thiamine. Further research and clinical trials are still needed to prove the sepsis cocktail value in the treatment of sepsis. Sepsis does remain to be a serious and common life-threatening condition that is marked by systemic inflammation, hemodynamic instability, and vascular compromise. Merrick's results provide encouraging data when using the vitamin C, hydrocortisone, and thiamine, and their effectiveness when given together to treat those critically ill patients. And it has shown to synergistically reverse those pathologic effects of sepsis that do progress those patients to organ failure, septic shock, and eventually mortality. This cocktail is inexpensive and readily available, and it has the potential to reduce progressive organ dysfunction and overall global mortality from sepsis. Additional studies are still needed to confirm these findings. There are clinical trials underway, and those will be finished at the end of this year. Since the patient in this case study that I presented above is not a surgical candidate, he may benefit from this type of alternative therapy. However, there needs to be more clinical trials on this before we do deliver it to patients, even though no risks have been identified. This therapy is something that all advanced practice nurses should follow, as it can mean having a cure for sepsis and reducing the overall mortality rates for severe sepsis and septic shock. And here are my references.